Well, thank you all so much for joining us this evening for our Girls Night Out Skin Cancer Screening event. This is just so awesome to be here with you all after a long, long time of not being around other people. I'm just so grateful. We are also so grateful to have Dr. Kelly Thomas here with us today. She is a dermatologist over at Glenwood Medical Associates and just graciously has agreed to let me twist her arm to do some public speaking, which is not her forte, but is graciously agreed to do it today. And we know that skin cancer screenings and prevention are so very important, so it's great to have her here, and I think it's just so important for everybody here. Just a note of logistics for those of you out on the Zoom call, hello, thanks for joining us. And if you have questions, etc., please type them in the chat and we will get to them at the end. And then also there will be a nice Q&A time after the talk that we'll have available as well. Great. Dr. Kelly Thomas.
So as Han said, I am very nervous to be here. This is not what I love to do. So I'm sorry. So anyways, I'm here today to talk to you about skin cancer and skin cancer prevention. You already know who I am, so we'll switch slides. So why is this such an important talk? Well, skin cancer is the #1 cancer in the world. That includes basal cell, squamous cell, and melanoma. You can switch slides. So why do we care that it's the #1 cancer in the world? Well, 5.4 million cases of basal cell and squamous cell are diagnosed every single year in the United States. That's a lot of skin cancer. This accounts for $8.1 billion of our healthcare money. That's a lot of money to be spending on skin cancer, and that's why we care so heavily, because so many people in the United States get this, and it costs a lot of money to treat. 1 in 5 of us in the United States will get a skin cancer by the age of 70. Next slide. So who's at risk for getting skin cancer? Most of us in this room. So we live in a very sunny climate. I think Colorado has 300 days of sun exposure a year, so it's beautiful to be here. That's why we all live here. We also live at altitude. We are on these beautiful mountains. Altitude plays a role of our increased risk of skin cancer. Some of us have used tanning beds in the past. Of course, nobody's doing it now. We know that's bad, but a lot of us have had tanning bed history. Also, some medications, some cancers can also increase your risk of skin cancer. Can switch slides. So, being fair-skinned is also a big risk for skin cancer. Being a fair skin, your body should be living at a northern European latitude where there's about 1,400 hours of sun a year. Well, that's not where we live. We live in sunny Colorado where there's 3,200 sunny hours a year, more than double what your fair skin should see. The people who should be living in this area should have darker skin, like the Ute Indians, and they developed that over centuries to protect themselves from that sun exposure. We are migrating way too fast to these beautiful places for our skin to keep up with that. Switch slide. So this is a really cool slide. Ultraviolet radiation is the part of the sun's rays that actually increase our risk of skin cancer. They cause skin cancer. Can you go to the top of the slide? This is from the Environmental Protection Agency. So this just projects the ultraviolet exposure on a month-by-month basis. Follow Colorado. You can see right in this area, our range, even in January, is one of kind of the middle of the country. It's kind of on par with Georgia and even parts of Arizona. Well, as you flip through, especially as we're getting closer to April, we are one of the highest UV radiation exposures in the United States. We are beating, go to July. In July, we are the highest place in the country for ultraviolet radiation. We are at risk living where we do for this huge ultraviolet exposure. From April through September, we're on par with the hottest zones in the United States. So yay, us living here. You can shut that down. Pretty crazy. I was shocked.
Whoops.
Perfect. So once again, altitude. For every 3,000 feet we climb, we increase our ultraviolet exposure 10 to 12%, which is why living up in these beautiful mountains, our ultraviolet exposure is so high. But also our airline pilots, our astronauts, they are at a hugely increased risk for skin cancer and melanoma. You can switch slides. Also, one of the fun things that we do around this area is play in the snow. Not only are we at altitude, but the snow reflects 90% of that ultraviolet radiation. So we're getting almost double the amount of UV radiation up on the mountains when we're enjoying. So cover up. All right, tanning beds. This is a fun slide. With one prior tanning bed exposure, your risk of basal cell increases 29%, squamous cell 67%, and melanoma 23% with one exposure. And I know even my husband said, oh my, I'm in trouble. Because a lot of us were stupid when we were young and did things like use a tanning bed because we thought us, tan skin looked really cool. The CDC put out this information saying if they can prevent anybody below the age of 18 from using a tanning bed, we're going to prevent 6,700 deaths from melanoma alone and 67,000 cases of melanoma. That's huge. That's why there's so much legislation being put in place to try to prevent our teenagers from using tanning beds. One, they don't understand the repercussions of what they're doing. And two, that's a lot of people that we could save. Right? So what are we here to talk about? So the most common things that we see in a dermatology practice are precancers, basal cell, squamous cells, and melanoma. Next slide. So my husband, when we were talking about this, he said, well, what does that mean? Where did these cancers come from? Well, at the very top, so the top of the slide is the top of your skin. That's your outermost layer of the skin. This entire slide is a picture of what's called your epidermis, which is your the top part of your skin. Your skin starts growing down at the bottom and then raises to the top, forms that nice protective barrier. Well, precancers are caused by sun coming from the outside world, touching those abnormal or those top skin cells and mutating them. They become mutated, they don't fall off like they're supposed to. Once they're mutated, they can start to grow and they can turn from a precancer or just damage just at the top to a full-blown skin cancer. And most of the time that turns into a squamous cell, which is the skin cells right in the majority. Sorry, I'm short of the skin, thank you. Along the basement membrane, so this is the bottom of the epidermis, most of the cells are called basal keratinocytes. That's where basal cell skin cancers come from, right along this border. There is no pre-basal cell. A basal cell always invades deep. So a basal cell is always a malignant cancer. Every 10th cell on that basement membrane is a melanocyte. Those are these pigment-producing cells that upon sun exposure, they don't move. They just release this pigment to help cap our little DNA right here to protect the cell from the sun so that skin cell doesn't get damaged by UV exposure. So these cells are supposed to stay right here and just release that pigment when they see the sun. That gives your skin the darker color when you have that ultraviolet exposure. With a melanoma, these cells, especially what's called a melanoma in situ, these cells start to move up. So they're not staying down here, but they start to move up first. And then when they break down below, kind of like a basal cell, that's a malignant melanoma. So when they start traveling up, that's in situ. And when they break down, that's an invasive melanoma. Next slide. So the most common thing we see, and something we even saw today while I was doing skin checks, were actinic keratoses. Actinic keratoses are also called precancers. This is often the first sun damage that you'll see. It presents as little red, rough, scaly spots. It can be isolated, like one little tiny spot, or you can have an entire area that's filled with damage. When it's just one little isolated spot, we can freeze it, we can get rid of it super easily. But if it's a big area, freezing this entire area would really hurt. I'm sure some of you have had liquid nitrogen. It doesn't feel good. So putting a cream on it does a much better job of getting rid of all of that damage, and it's much more specific than just freezing. Next slide. Basal cells. Basal cell is the #1 skin cancer in of its own. 3.6 million basal cells are diagnosed every year. Basal cells often present as a pimple that won't go away, or a bleeding sore that won't heal. Oh, I nicked myself shaving. Oh, I got a bug bite. Oh, I got a pimple, but it's not healing. It often looks dome-shaped, almost pimple-like. And then over time, it goes from a nice bump to an ulcerated, even really bad, open sore. Please don't let them get that bad before you come in to see us. Next. So for basal, one more time back. For basal cells, what we normally do is do a biopsy of it, confirm that it's a basal cell. Sometimes on that same visit, we can just remove it right then and there for you. Sometimes we have to do further excision or Mohs surgery or radiation. Really depends on how deep, how ugly. The ones on the back, you'll be seeing Dr. Marcus for that one. The one all the way over on the right side. All right. So basal cells oftentimes are more that pearly bump, but sometimes they can present as just little flat, rough, scaly spots. So sometimes it's hard to tell unless you look with our our magnifying glass, our dermatoscope, and tell that there's other features of the basal cell. These are nice and superficial. These are super easy to remove, and we normally just do it right then and there. All right, next slide. Squamous cell. So this is one caused more by that cumulative sun exposure. It's that rough, scaly spot that just keeps growing, gets more tender, starts to bleed. This is often in sun-exposed areas. Hands, face are the most common areas for this. Freezing it sometimes works, especially if we're not sure if it's a precancer or just turning into a slightly deeper or a slightly superficial skin cancer. But oftentimes we cut these out and send you for further removal. Next slide. And melanoma, the one you never want to hear when you get a phone call back. Of all the cancers that are tracked, melanoma ranks as the 7th most common. Breast cancer is the #1. 122 out of about 100,000 people get a breast cancer every single year. Versus a melanoma, it's about 22 out of every 100,000 people. I think these lower statistics are really interesting. We were saying earlier that altitude really plays a role. Look at Gunnison County. The national average is 22 per 100,000. Gunnison County is at 48 per 100,000, almost one of the highest in the country. So we are at a higher risk than the national and state average, but not nearly as bad as living in Silverton. So what do we watch for melanoma? We call it the A, B, C, D, and E of melanoma. A stands for asymmetry. One side of the mole does not look like the other. If you see that, have somebody take a look at it. Borders. Moles should have a nice, even, round border. But if it starts, I tell people, having arms and legs, you want to have somebody take a look at it. Color. It is normal to have 2 colors in a mole as long as they're evenly distributed. Light in the middle, darker on the outside, lighter in the middle, as long as it's a nice, even pattern. Diameter. I honestly do not use that one at all because we find melanomas that are 1 millimeter big. So diameter, something for you to watch out, more so for evolution. This mole is changing. It is growing. It is doing something. So if you have a new growing, changing mole, have somebody take a look at it. Next slide. Some fun pictures of melanoma. You can see it really follows the patterns of the A, B, C, D, E's. They're ugly looking. This one right here I thought was kind of interesting. This is the top of a gentleman's head. But when you look up close, you can see the pattern is not nice and even. It is it's all over the place. So a spot like that, we would take off, biopsy, find out that is a non-invasive melanoma right there. Next slide. So what can you do now living in elevation in our sunny climates? We know we're at risk. What can we do? Protect yourself, cover up. All of us live here because we like to play in Colorado. We like to hike in the mountains. We like to bike. We do all the things outdoors, and that's what really drew us to this area. And there are ways you can still do all those sports very safely. So I have switched to long sleeve jerseys when I'm biking. I wear the longer capris. When I'm hiking, try to really cover up long sleeves, big sun hats, even hiking gloves, or actually even I use my biking gloves for when I'm hiking, just so that top of the hand doesn't get affected. I even found tennis outfits because a lot of my tennis players use more of a visor and short sleeves because that's the cool thing to do. But I did find some tennis outfits that were long sleeves, so I know they're out there. Also on the beach, just cover up. Besides clothing, hats, sunglasses, a UV protection of 400 or higher. It's what's recommended by the American Academy of Ophthalmology. So just look for UV 400 protection and you should be safe. Excellent slide. Also, just remember, UV exposure is cumulative. When you go and walk your dog, you're getting that ultraviolet exposure. When you go to the mailbox, when you go to the grocery store, all of this adds up for that time in the sun causing that ultraviolet damage. When you're driving in the car, just think about the sun exposure you're getting and protect yourself. Next slide. Seek shade, common sense. The highest ultraviolet exposure during the day depends on what you read, 10 to 2, 11 to 4. So kind of in the middle of the day. You want to make sure that if it's July and you're on the mountain, try to get off the mountain before noon. Really protect yourself both from the weather and from the sun. All right. Sunscreen. So in areas you can't cover up, use sunscreen. The American Academy of Dermatology recommends an SPF. Make sure it's broad spectrum. I think most sunscreens out on the market these days are broad spectrum, so you should not have to look for that. Also, with sunscreens, there's been a lot of new rules and regulations and safety concerns with sunscreens. So at this point in time, zinc and titanium have gone through extensive testing. We've had them on the market for years. It's what makes up baby's butt paste. They're considered safe or glossy, generally recognized as safe. The ones that are not safe have been pulled off the market for years. And then there was some concern over a study about a year ago showing that the other sunscreens we use, the avobenzones, oxybenzones, we are getting some absorption. We don't know what that means. We don't feel it's going to lead to adrenal cancer like it did in rats, but we're doing studies on this. But at this point in time, the American Academy of Dermatology stance is all sunscreens are considered safe, but there still are ongoing studies to make sure that we verify our own, thoughts with that. All right, next thing. Other things that you can try. So niacinamide is a really neat vitamin. It's a B vitamin. It's used for cholesterol. It's used for energy in a lot of B vitamin complexes. But some studies, and actually a lot of robust studies, have shown 500 milligrams twice a day has shown a 20 to 30% reduction in basal cell, squamous cell, and actinic keratoses while you use it. Once you stop using it, that benefit disappears. So unfortunately, it's not something you can just take and then you're good for the rest of your life. You do need to keep taking it. Now, personally, I don't know why that's the case, but it's a pretty cool vitamin to take and really no side effects with it. The other kind of fun thing is a product that's also been on the market for about 15 years. It's called HelioCare. It's a sunscreen pill. It gives you an SPF of about a 3 to a 7, so it is not a replacement for your sunscreen. This is if, oops, I'm outside a little bit longer and my sunscreen has worn off, it gives you a little bit of protection from that damaging ultraviolet exposure, has a lot of antioxidants. It's a fern root extract. It was a plant that went from aquatic to terrestrial life, had to figure out how to survive the beautiful sunny days, and they have discovered that this is beneficial. Once again, it is not a replacement for sunscreen. It's just an additive. There's a newer one that HelioCare makes as well. It actually combines the two. So kind of cool. All right, now Dr. Butterfield and Dr. Marcus, come on up. Does anybody have any questions for all of us?
Oh, thank you.
Thank you very much. Well, I'll just introduce myself real quick. Dr. Thomas, that was a great talk.
Excellent,
and I
thank you.
certainly learned a lot. I'm David Marcus. I'm one of the radiation oncologists. And as Dr. Thomas mentioned, radiation therapy sometimes serves at kind of a backup role. Many of the non-melanoma skin cancers are either easily excised in the office or a simple surgery. And that's where Dr. Butterfield often gets involved. For certain cases where surgery is not the ideal option, we can use radiation therapy. And so while that's not often considered the primary therapy for skin cancer, it is something that we do in the cancer center that really does play a role. And it's something that, a lot of people are not aware of. So I'm certainly happy to take any questions or answer any questions about the role of radiation therapy in the management of skin cancer. And I'll let you
Thanks.
introduce yourself.
Hi, so I'm Jen Butterfield. I'm a plastic and reconstructive surgeon. And my role is interesting. Sometimes I'm involved in the primary excision. I may see, one of Dr. Thomas's patients that, may have a basal cell or a squamous cell carcinoma, and I may be involved in just excising it. And sometimes if it's a lesion that's on the face, an important anatomic structure like the nose, the ear, or a place where we're trying very hard to conserve as much tissue to avoid deformity, that patient may get referred to more of a dermatologist that's specializing in Mohs surgery, and then I may get involved in reconstruction. So I have kind of an interesting role of sometimes excising things and sometimes helping to reconstruct defects that are caused after another surgeon did the excision. Kind of, again, along the same lines, for those melanoma, diagnoses, again, if it's a non-invasive melanoma, I may be involved in excising those, but for those more invasive melanomas that are fairly deep, those sometimes require lymph node removal, and I'm typically not doing that, so.
It's always a team approach.
Yeah.
We definitely rely on each other.
I have a question for you, Dr. Thomas. So we saw these pictures of all these people behaving beautifully with their long sleeves and their brimmed hats and everything like that. And one of the questions that I feel often comes up that I'm not entirely perfectly equipped to answer is, what about vitamin D? Aren't we supposed to expose our skin to the sun to get adequate vitamin D? And how do we balance those two goals?
It's a very good question. So once again, in that picture of fair skin, our skin is fair or becomes more fair the further north our ancestors migrated, so we could absorb more sun to get that vitamin D. So the whole purpose of that lighter skin was to get more sun in to get that vitamin D. However, we know that sun is cancerous. In today's world, we have a much easier, much safer, non-cancer causing way to get your vitamin D through oral supplementation, whether it be through a diet with vitamin D rich foods, or talk to your primary care about just doing an over-the-counter vitamin D supplement. Honestly, there is no beautiful vitamin D level that we know of yet. We know it's important. We know it's a hormone. We know it does a lot of great things for the body. But there are a lot of studies trying to figure out what that optimum vitamin D level is. Don't be deficient. Don't try to get your vitamin D from the sun. There was even a study on Hawaii surfers and found that they were vitamin D deficient. So I say, get your vitamin D, but be sun safe. You can easily take a pill or eat a different vegetable that has more vitamin D in it. And it's interesting, they're wondering about vitamin D for reproductive issues, not, other things. And that's why we needed it with fair skin, because it wasn't later on in life that we needed the vitamin D, it was early on in life. So kind of interesting.
It's a great answer. Thank you.
There's one other thing that I think it's not totally self-serving, but marginally self-serving, which is that, can you tell us a little bit about the different kinds of UV light? Because I think it's also interesting that there are other types of UV light that we're all getting actually right now that can lead to some photo aging or aging.
Yep. So the 3 types of ultraviolet rays are UVA, UVB, UVC. UVC is blocked out by our ozone layer. We don't get UVC here, so it doesn't cause any problems for us. UVB and UVA both do reach the earth. We are exposed to UVA and UVB rays regularly. UVB causes skin cancer. That's why the original sunscreens were SPF so-and-so. They were blocking the UVB. But what we've realized that the UVA actually goes down deeper in your skin and causes mutations and growth of those skin cancers that were caused by that UVB. So the UVA kind of just generates and lets those skin cancers grow. Visible light, I don't know that we think is carcinogenic, but it definitely causes photo aging. It causes our brown spots. It's awful for melasma. So we know it ages the skin, but I don't know if it's cancer causing.
Right.
But yeah.
So I think, it was always surprising to me, like I always sort of figure, well, if I'm going to be out on my bike, I'm definitely going to put my sunblock on. But if I'm hanging out in my office, I don't need it, right?
Nope. You need it
I need it in
every
the office,
single day.
Because in the office, I'm exposed to
Visible light.
UVA light, and that can make me look old.
Mm-hmm. And the visible light,
Yeah.
plain visible light, not even ultraviolet. And we can actually block that visible light with tinted sunscreen. So it's the iron oxide component in a tinted sunscreen that actually blocks visible light, and visible light darkens your brown spots. So really nice that if you are using a sunscreen and you are indoors, it's a great additive because you're helping yourself with their visible light as well.
Yeah, thanks.
Mm-hmm. Yeah. Questions?
Is there a genetic component? Because aren't there places you can get melanoma?
Yes, so good question. Good question. So they feel well over half of melanomas. I think they think 80% of melanomas have some form of sun exposure culprit. But you are absolutely correct. There is a genetic risk for melanoma. You can develop melanoma where the sun doesn't shine. One of my first experiences was actually in Tucson. There was an 18-year-old gentleman who had been in prison, and he had a melanoma in a very private area, and he had not exposed himself to the sun. And so there was definitely a genetic risk with that location. You can see it the perianal area. You can see it, places where the hair has been covered for most of the life. So yes, there are genetics to melanoma, but we feel the sun plays a heavy role for most melanomas.
Will mold turn into something bad, or
So both. So we don't feel a traditional mole has any higher risk of any other area on the body to turn into melanoma. But a mole that's new, we always worry about. You're not supposed to get any new moles after the age of 30. So if you get a new mole after the age of 30, get it checked out. Now we can grow a lot of other spots and they're perfectly fine after the age of 30. But even if you get a new mole younger and it's changing and it's growing and it's not just sitting there as a bland, boring looking mole, yes, it can change, but often it starts on its own.
I have a question. So, my friend uses one 40 days. I use another 40 days.
Yeah, for sure.
How do we know if they're really the same? They're probably not the same, is my guess. It's because it feels good going on. I don't know.
So what I always tell people is find one that works for you. With your skin tone, wear a sunscreen where you're not burning when you're using it. I have a different one that I like than what my husband likes and what my father likes. So we all have different preferences for what texture, what feel. As long as you're not burning with it, as long as you're going to wear it, I don't care if the SPF is 30 and you're not burning or 60 and you're not burning, as long as you find one that works for you. Probably not.
No.
Probably not. Yeah. The problem with sunscreens is they're not beautifully regulated. They're not a pharmaceutical, they're a
Right.
cosmeceutical.
Right.
So they're not well regulated. So find a company that you trust that you don't burn with and use it.
Yeah, I mean, I think that's a great piece of advice. I think, because I feel the same way. I have 2 or 3 different sunblocks that I like, and they're, all of them are between 36 and 40. And I know that some I feel I never get any redness with them, and there are some that I put on that really ought to be fantastic, and I feel like I have to reapply a lot more often, and that I still get a little bit of red. So I agree with you. I agree with you. I think you need to find one that you use that doesn't really change. You don't get red with it, that you can tell that you're not getting sun exposure, sunburn.
That's a red hat, they expire.
Yep.
Mhm.
1 year normally.
Mhm.
Yep. So if most sunblocks nowadays do have an expiration date on them, and normally they're between 1 and 2 years. The older ones have no expiration date. So if your sunscreen doesn't have an expiration date, throw it away.
Mhm.
They've had those dates for a couple of years now.
Yeah.
Yeah.
Is spray sunscreen equal to sunscreen?
So what I always say is, if you have it, use it. So I like applying a lotion first. I think it goes on more evenly. But I do like sprays. I have kids, and I think the spray sunscreens work great. But a lot of people use the spray sunscreens wrong. You need to spray it, then rub it, then spray it, then rub it. Because you've all experienced where you've just gone whoosh, and you have a line. So you have to spray it, rub it, so you get that nice even distribution. Spray it, rub it. That way you get enough sunscreen. And the optimum amount of sunscreen for a full body application is a shot glass worth. It's a lot of sunscreen, and we're not probably using that much. So for me, I've realized covering up is much better than relying on my sunscreen because you need to apply.
I think too, the UDF, like I have a lot of those sunblock shirts.
Yeah.
And I have to say, I'll go biking and then I'll come to the office and be like, "I'm so red," and I've been wearing my sunblock, all weekend. And I sort of feel like maybe that washes out. Like, I think maybe those should be replaced periodically too.
I always tell people, as long as you can't see through them, they should be good enough. The weave is tight enough, but if you can see through the shirt, it's really not a sun shirt. So any clothing, I'd say wear it. It's probably better than not wearing it. I haven't had that experience with my biking jerseys yet. Maybe I haven't used them enough.
You mentioned mode.
Yeah, yeah. I can try. It's easier usually with a diagram. But so the idea behind Mohs surgery is to excise a cancer with the least kind of hole that you create as possible. And so these are dermatologists that are specialty trained to be able to take out the lesion, and they kind of quarter it like a pie. And then they take that to the microscope while you're in the chair, and they match the pie to kind of what they see in the microscope. So they know kind of like if they were to mark your hole where they took it from, like 1 to 8 or 1 to 4, they know that like this slide came from 1. If there's a little finger of cancer still at the edge, they go back and they take a little bit more from 1. Or if it's 3, they can mark. They can tell where in the cancer they maybe need to take more of, and they can go back to you while you're sitting in the chair and take it. So the cool part about it is that you already have your margins or the edges of it looked at before they ever let you leave their office. And sometimes it's the first go, and sometimes it might take 3 or 4 goes to get it all. But the benefit doing it this way is that theoretically you have a smaller hole when they're done with you than if you come to me and I'm like, well, it's a basal cell, I better take a 0.5 centimeter margin, and then it's a bigger hole than you would have had if you'd had it done by Mohs.
I've heard of it. I just didn't exactly know.
Yeah.
I don't do Mohs. We have a provider in our office that does do Mohs and works closely with Dr. Butterfield at times too.
It's like a lot of times we'll coordinate surgeries. If one of our patients, like if Dr. Thomas refers a patient to me and the Mohs surgeon, then we'll like coordinate our calendar so that you go to the Mohs surgeon in the morning and then you come to me in the afternoon and I kind of fix it.
other questions?
Well, are there any other questions? We can take one more. Okay. Well, thank you all again so much for joining us, and thank you, 3 respected physicians here to join us. And gosh, it was great evening.
Thanks so much for
everybody.
coming out. This is
Yeah,
so
appreciate
fun.
it.
Good to see you all.